Awesome. Thanks for the invitation and thanks for your attention. So I'm going to give a bit of a whirlwind tour of what I would consider some of the advanced imaging techniques that we have available here at UCSF and that we can use routinely. I'm not going to get into some of the more, I would say, translational type of activities, just in the interest of time. So when I was first putting this together, I was looking at a lecture that I gave to our radiology residents and fellows a couple of years ago. And the first question here was actually prefaced by saying, brain metastases are boring. Why should we study them? And as we learn more and more and we study them more and more, this couldn't be further from the truth. So I've just dropped that and just said, why should we study the imaging of brain mets? And I think we can answer that in the context of two questions. The first is, how do we detect and characterize brain metastases? And the second is, what happens to brain metastases after treatment? And how can we use imaging to assist us in both of those time points? So as you've heard earlier today, thematically, we've talked a lot about the challenges in treating brain metastases. These challenges that exist with treating brain metastases also exist with the imaging of brain metastases. As you probably are all very well aware, our primary imaging technique, MR with contrast, really relies on changes to the blood tumor barrier, and so or blood-brain barrier, I should say, and so that certainly comes into play. We've talked about the uniqueness of the brain microenvironment, genetic heterogeneity, and our greater understanding of that. We don't really, I think it's worth highlighting that we don't really have optimal timing and I would say set up for using the different not just treatment, but imaging modalities as well. And so this is from Marisa, showing just highlighting just the diversity of targeted agents that exist now for several of these common brain metastases. And I would say for imaging, let me back up here. Oh, sorry, I can't back up. Can you back me up one? I think it's worth highlighting that we have all of this here, and I'm thinking now about how I can best update to the slide, and we can put something here that shows standard of care imaging, which is really just, MR with contrast, so T2 flare and T1 post-contrast images. And I think we need to bring imaging up to where we can think about more targeted types of approaches. And so I want to just quickly highlight, we've talked about some of these new treatments on the horizon. I want to talk about focused ultrasound briefly, just because it's of high interest. And yesterday, we happened to do our first clinical case using MR-guided focused ultrasound in the setting of a patient with essential tremor. With really good results. I have a picture of that I'm happy to show anyone after. That looks really, really cool to see the differences before and after lesioning. But as Marisa mentioned earlier, MR-guided focused ultrasound, low-intensity MR-guided focused ultrasound with the use of microbubbles to disrupt the blood-brain barrier and assist with treatment is a very exciting, new, promising technology that gives us high precision. So here you can see a checkered ward pattern that was made using activation of different components of the device. And here you see that the changes that we appreciate are transient. So at baseline, no contrast enhancement. Following MR-guided focused ultrasound, you see contrast enhancement consistent with disruption of the blood-brain barrier. We don't see any hemorrhage here on T2 star-weighted imaging. And then rapidly following this low-intensity focused ultrasound, we see resolution of the disruption of the blood-brain barrier. So it's precise. We know it works, and we know that it is transient. So those are all helpful features for us. Marisa talked about this clinical trial, so I'm not going to touch on it. But I do want to just quickly introduce one of the neuroradiologists who we recently just hired, Kazim Narsing, who's our neurointerventional radiology lead for neuro-oncology, and he's kind of our point person for these trials as we get them off the ground. So just want to take a minute to introduce him. And as I mentioned earlier, we did our first clinical case yesterday. We're doing 2 of these cases twice a month So 4 cases a month, building up experience, expertise with this that we think will drive our research efforts, such as the trial that Marisa mentioned earlier. So moving on to kind of the meat of what I want to discuss today, which is how do we detect and characterize metastases, as well as how do we evaluate metastases after treatment. So here I want to highlight, just by way of example, a couple of challenges that we face in the reading room and in the clinic. So if I were to pose these 4 different cases to you and ask you which of these is a brain met and which of these is a glioma, I think it's a bit of a challenge to really make that differential diagnosis. And here I've marked out which ones of these are gliomas and which one of these are metastases. They can be solitary or multifocal, as you see here. And then there are other things that could be considered in the differential diagnosis, right? In the appropriate clinical setting, these could be abscess or lymphoma, for example. So it's not as cut and dry as we make it out to be. So how can we differentiate at the time of initial diagnosis of lesion? Well, one thing we can do is we can look at the surrounding tissues. So looking at the edema and try to understand the difference between vasogenic and infiltrative edema. Here I have 2 examples. One is using MR spectroscopy outside of the lesion here. And you can see that with glioma, you have what's known as a reversed Hunter's angle, which is an elevation of choline, which is indicative of membrane turnover, a reduction in NAA, a normal neuronal marker. Whereas in metastases, you don't have that infiltrative edema, so we don't see an elevation in choline in the surrounding edema, and we see relatively normal NAA. We also have other techniques such as T1 row imaging that help us. This is pH sensitive imaging that helps us identify more homogeneous signal intensity around the vasogenic edema versus greater heterogeneity in the setting of glioma with infiltrative edema. Now, I think a greater challenge that we face routinely is how do we detect lesions, right? So for us, we have a saying in radiology, a lot of times it applies to pulmonary nodules. It's 1, 2, 3 enumerable. Unfortunately, we don't really have that luxury in the setting of brain metastases, because we often we'll go through and treat many of these, and our record is looking at about 60 of these in one session. So it's a very painstaking, long, arduous process for our fellows who are doing this work, and then for the other neuroradiologists who are reviewing it afterwards. So it's ripe for automation, and we have a brain tumor segmentation, detection and segmentation model that is ready to be deployed. We're deploying the brain tumor segmentation model first, but this is ready to go, and this has equivalent performance to radiologist detection for lesions that are greater than 5 millimeters in size. So 5 millimeters or greater in size, I should say. So we're really excited about this, because this is going to be a workflow enhancement for us, as well as potentially a better ability for us to track metastases over time, provide volumetrics, and to be able to call out, okay, these are ones that were treated. We can flag them and identify new metastases more readily. We also, you probably maybe heard about this using either Cube or Space. These are vendor-specific terms for what is a 3D spin echo T1 post-contrast sequence. These have been shown to have greater sensitivity for detecting metastases. So if you look at screen at bottom left here, what we show with this orange line is the ground truth, and the number of metastases that are detected using Cube is greater than the number of metastases that is detected using Bravo. In fact, actually above the ground truth here in this study for 2 raters. And then out of the Miami group, Mike McDermott and his team showed not just greater detection, but also better outcomes. So improvements, reductions in risks of distant failures when 3D spin echo sequences are used. So this is something that we're looking to reintegrate into our protocol. Some of you may be familiar with the fact that we actually integrated this into our imaging protocols probably about a year or 2 years ago. Unfortunately, due to some technical limitations, we found this to not be as helpful as we liked. And I think there's some ongoing discussions in the background around how we can integrate this better into our imaging workflow. So look out for that in the future. And now, really, I think the challenge, so those are kind of challenges that we face on the radiology side, but I think clinically, one of the greatest challenges we face is what happens to brain mets after treatment, as has been alluded to by several of our prior speakers. You can have fantastic outcomes where you have here somebody pre-SRS and post-SRS, you see disappearance of the lesion. However, it's not uncommon for us to see small lesions such as this one on screen right, and the follow-up period become much larger with more necrosis, more edema. And so we're often left scratching our heads. Is what we're seeing post-treatment change, or is what we're seeing truly progressive tumor? And everybody's favorite line in radiology reports: could represent post-treatment changes or progression. Trust us, we hate saying it just as much as you hate seeing it in your reports. So what can we do? What's at our disposal to try to answer this question? Well, there are qualitative and quantitative features that can be looked into with anatomic MR. A lot of times, we look at things like, well, how much edema is there associated with the lesion? Is there a lot of edema? What's the time frame from treatment? Are there changes in susceptibility? To try to standardize this, people have suggested things such as the lesion quotient, which is the ratio of edema or T2 signal to the ratio of the enhancing lesion. In practice, we don't routinely use these. In practice, we really rely more on some of these other techniques down here, I would say, such as diffusion and perfusion weighted imaging, and MR spectroscopy to a lesser extent. But we really, I think of these three, we probably rely on perfusion a fair amount. You'll see an ASL perfusion, a non-contrast perfusion technique used to help us differentiate. And here, just an example of a post-treatment lesion without much elevated perfusion, favored to be a treatment effect and subsequently confirmed to be such. Now, beyond MRI, I do want to spend a couple minutes talking about PET imaging, which is employed here at UCSF in the investigational setting. And really, I'm going to focus on amino acid PET imaging, which functions via this mechanism here. There's two sets of amino acid transporters that are expressed in malignant cells, both LAT or L-amino acid transporter, and then ASC2 transporters here. And the imaging agents that we look at with these here at UCSF are F18 FET or fluorethyltyrosine, it's a tyrosine analog, as well as FACBC or fluciclovine, which we looked at in a trial setting. And interestingly, and perhaps beneficially for us, is that there's increased expression of these transporters in the context of metastases, as I mentioned earlier, but there's actually even greater expression in recurrent than new metastases. So it's even more helpful, or it suggests that this would be even more helpful in the context of differentiating recurrent tumor from treatment-related changes. And we just participated in a multi-site trial using FACBC or fluciclovine. This is an amino acid analog that was first designed for use in glioma. Didn't really have much success there, and has actually been used a lot in prostate cancer and has a label for prostate cancer. And so they're seeking a label for use in the setting of metastases. So two clinical trials just ran. I'm going to show these here. Both Revelate and Pursue phase 3. This is what we participated in this phase 3 to differentiate recurrence from progressive mets following stereotactic radiosurgery. We enrolled a couple patients and expect those results, I think, by SNO. So look out for that coming soon. And then they had another phase 2B trial to investigate the interpretation criteria. I'll show you. So while that has closed, we're still enrolling patients for another amino acid study, another amino acid PET study using fluorethyltyrosine. This is with Tom Hope from our molecular imaging group. This is just an example patient pre and post RT showing growth of a lesion, more edema. Came in for PET-MR. This showed a tumor to background ratio that was high, suggesting tumor. Went on to get surgery, and at least 50% of the resected tissue was found to be a recurrent tumor. One of the interesting things we're finding with this is that the greatest experience exists with amino acid PET in the setting of glioma. And what many people are trying to do is apply the same interpretation guidelines for glioma to metastases. And I think that that's not going to pan out based on what we're seeing. Metastases tend to have different types of uptake, not just static, but also dynamic uptake. So it'll be, I'm looking forward to see what the fluciclovine trial shows, because I don't think that I don't think it's directly translatable between glioma and metastases. So just back to our initial 3 questions: why study imaging of brain mets, increasing incidence, better understanding, and new targeted therapies? How do we detect and characterize metastases? I think MRI honestly is just fine. There's minimal role for PET and molecular imaging. However, there is a huge role for AI-based tools in the near future to help us detect and track these longitudinally. And then for the differentiation of radiation necrosis from recurrence, there's a huge potential benefit of PET imaging, particularly in the context of a hybrid scanner like we have here. We have a hybrid PET-MR scanner where you can get both the PET and the MR data. There's a potential role, I think, for response assessment in new therapies that we didn't really get into. And as I mentioned, we didn't talk about some of these other types of imaging approaches that are maybe a little bit more not yet ready for routine clinical use. So with that, acknowledge a couple collaborators, and thank you all for your attention. Happy to take any questions.